Okay, well, it's a pleasure to say hello. My name is Dr. Eric Hollander, and I'd like to introduce our mini lecture series at the Spectrum Neuroscience and Treatment Institute. Today we're going to be focusing on obsessive-compulsive and related disorders, and I have two international experts in this area with me. Professor Stefano Pallanti from the University of Florence, and Dr. Steven Poskar, who's a psychiatrist and an expert in cognitive behavior therapy for obsessive-compulsive disorder. So we'll give you a little bit of background in terms of what obsessive-compulsive disorder, or OCD, is. We'll talk about some of the standard clinical treatments and then some new approaches as well. And I'm really excited to be here with my colleagues here. So obsessive-compulsive disorder is a relatively common mental health disorder. It's characterized by disturbing, intrusive, obsessive thoughts and compulsive rituals or habits. It's associated with a lot of distress or discomfort and impairment in functioning. And there are a number of different types of obsessive-compulsive disorder, different kinds of symptoms. Stefano, maybe you can describe some of the different types of symptoms that you see in OCD.
Yeah, obsession can be also just doubt. No, doubting is one of the four people that is always doubting about any tool, or can represent by an impulse that is difficult to deal with, or in some other case can refer to some specific content like contamination, like or being aggressive or symmetry ordering. I mean, so there are many forms of obsession, and it depends from there are some specific content for specific form, like postpartum onset is characterized by aggressive thought and difficult to manage this kind of thinking. So
now, Steve, are obsessions and compulsions in OCD really the same worries of everyday life?
No, so usually obsessions are kind of, often obsessions target really what often patients fear the most. And so for people with kind of religious obsessions, they're often very kind of specific, intrusive thoughts about thoughts of blasphemy. Often people will have obsessions regarding harming others, either intentionally or accidentally. And so these usually are very kind of distinct and kind of discrete concerns that are usually outside of the day-to-day worries that most people would have, or that we'd see more commonly in disorders like generalized anxiety disorder.
Mm-hmm. Are there any new developments in DSM-5, Dr. Pallanti, with regards to obsessive-compulsive disorder?
yeah, I mean, now we are distinguished as Hoarding as a big cluster that is probably belong to OCD, but also can be present in some other mental disorders, and actually is one of the most difficult form to be treated with a traditional treatment for OCD.
What is hoarding?
Hoarding is a form of pathological collecting. I mean, but it's not. I mean, everybody have at some point during life some collection, but hoarding is accumulating things in a very dysfunctional way, creating even some threatening or danger for people that are living in that environment. And people that hoard can become very impulsive, aggressive in case you want to move some of the item they collect, or if you want to change their routine. So it's a very invalidating form of pathological collection.
Yeah, it sounds pretty severe. Are there any treatments for hoarding?
So hoarding, we do some, we do provide medications. Often kind of the standard pharmacological treatments often don't work as well. Serotonergic reuptake inhibitors, while sometimes show some success, don't work as frequently in disorders like hoarding, and behavioral approaches are more difficult. Probably one of the things that makes hoarding such a difficult to treat disorder, even compared to OCD, is there's what we would kind of call an egosyntonic component, that people actually get satisfaction often out of both the acquiring process, which is almost more of an impulsive process, and the keeping of items. Whereas in something like OCD, the obsessions and the compulsions are actually very disturbing to the patient. So often there's more of a drive for the patients with OCD to want to be rid of the disorder, whereas with hoarding, often it's not the patient but the family and friends who actually want the patient to get treatment, and that always makes the disorder much harder to treat when the patient isn't really actively involved in wanting help.
Right, yeah, that's a tough subtype, I guess, or a new type of OCD. And in DSM-5, obsessive-compulsive disorder was always considered an anxiety disorder, and now for the first time, obsessive-compulsive disorder is thought of as one of these group of obsessive-compulsive spectrum or related disorders, which can include things like body dysmorphic disorder, the distress of imagined ugliness, or people with trichotillomania, people who pull out their hair, for example, people with hypochondriasis, for example. So there may be other conditions that share features with obsessive-compulsive disorder that used to be classified in different parts of DSM, and now for the first time they're being grouped together and really placed outside of the anxiety disorders in their own grouping, these obsessive-compulsive spectrum disorders. What do we know about the treatments that work for obsessive-compulsive disorder?
Any guideline and all the evidence we collect so far in the last 20 years, because the history of the treatment of OCD started, quite recently now, to say, is that we have on the same line SSRI or CBT, and even if we have to define according to the preference some time of a patient, even if probably the high component of anxiety is a predictor for a response with CBT more than with SSRI.
Yeah, so I guess SSRIs are the selective serotonin reuptake inhibitors, so medicines like Prozac or Luvox or other medicines in that class. And although they're antidepressants, they block the reuptake of serotonin, they enhance central serotonin, and over time they regulate the serotonin system. And that can have big impact, for example, in some of the brain circuits that we think are involved in driving these obsessions and compulsions. And so there are at least 5 different medicines that are approved by the Food and Drug Administration for the treatment of obsessive-compulsive disorder, both in adults and in children. And in fact, OCD is an illness that often begins in childhood or adolescence. We think that there is a developmental trajectory, I guess, to OCD. People, what do children look like who present with obsessive-compulsive disorder?
So often children present, oftentimes with more of the compulsions, and often really can't even explain what the reason is. And so often children will turn on and off a light over and over again, or have kind of repetitive symptoms. Particularly in young boys, we see kind of what might be a separate subtype of OCD, where often not only do they have kind of OCD symptoms, but they also have comorbid tic disorders. Often these patients, their OCD takes the form of symmetry and order-related things. So things on their body or in their environment have to be symmetrical. And there's a question of, is this kind of a distinct subtype? And one of the things we're kind of continuing to look at, and a big thing in this area now is PANDAS, which is pediatric autoimmune neuropsychiatric disorders associated with strep, where it looks like a streptococcal infection can actually activate the areas in the basal ganglia that are responsible for OCD. And this might be a reason where kids will present often with either tics, OCD, sometimes new onset fears or eating disorder problems, and often changes in things like handwriting and coordination. And this is kind of a hot area where the treatment might be a little different than for standard OCD, and might involve things like immunoregulators like antibiotics.
Now, in Florence, what do people think about this notion of PANDAS, the pediatric autoimmune neuropsychiatric disorders associated with strep?
Actually, we are recruiting subjects, and we are considered probably the only center in Italy, so we are collecting several of these patients. We are studying all the immunological profile of this subject, either the cytokine, but also the activation. We are specifically we are studying the activation of the complement, because we are looking for some what's the way that the antibody are activated is not clear yet. But what is clear that we see this patient in some of the case they can have a very important reduction of the symptom with just antibiotic. That is very interesting as a result. I mean, we never see OCD symptoms disappear with antibiotics.
Right. Well, it sounds like a sort of a promising new area, the idea that inflammation may play a role, at least in a subgroup of individuals with OCD, in terms of exacerbating the symptoms. What do we know about the brain circuitry of OCD?
Yeah, and now we all the field of obsessive-compulsive disorders has been correlated to a fronto-basal ganglia dysfunction, and so we know that as a general idea that there is something that is dysfunctional between the connection of the basal ganglia and orbitofrontal cortex. But now we know that probably there are different areas, either at the level of the basal ganglia, like not only the amygdala or the caudate, that was the first part, but also of the insula, that are probably connected in a different way, and they respond for different form of symptomatology in the disorders. So we have a different approach, considering OCD as one disorder, but with underpinning several circuitry involved. And also a new notion is not only inflammation, but is also the notion of neuroplasticity that is coming on. And I think that is very helpful in understanding both the trajectory of these disorders in the pathological sense, but also sometimes to have a better understanding of the response to the treatment.
Now, we heard the word CBT before, and the idea of neuroplasticity. So can you tell us a little bit about CBT and maybe say something about why it might affect neuroplasticity?
And so CBT, is a group of treatments called cognitive behavioral therapies, and specifically in OCD, we use a very specific type of cognitive behavioral therapy called exposure and response prevention. And we know kind of quite a bit how this works through some things known as behavioral extinction. And this probably has something to do with the glutamate system, specifically the NMDA receptors in glutamate. And so we see that sometimes there are certain drugs being used, currently, such as things like D-cycloserine, which actually affect NMDA receptors and actually seems to increase the response possibly of behavior therapy. And so we do think that when we're making kind of behavioral changes and learning changes, this is very highly involved in the glutamate system, which is also a new kind of target of treatment in the past few years of pharmacological treatments for OCD.
What other new pharmacological approaches might there be?
I mean, as a second line, we know that probably some dopaminergic modulator agents can be helpful in some case, and also there is a large interest for all the glutamatergic new compound, even if for now there are not sufficient evidence to put this drug in a line. Probably we have after that we try with SSRI. We have probably to think about kind of personalization of the treatment, and also one of the possibilities that now has been proposed for the treatment is TMS, transcranial magnetic stimulation, that also is involved not only in the modulation of the cortical activity mainly, but also can be helpful in terms of correct some dysfunctional long-term potentiation, and can improve the learning even in association with CBT. This is a part of our experience. So it's a very complex.
Right. Well, it sounds like this is a very rich area, and that the science is sort of rapidly expanding, and then some of those science developments are feeding in and modifying our treatment approaches. And it seems like the APA practice guidelines suggest that the standard first-line treatments are either the selective serotonin reuptake inhibitors or cognitive behavior therapy, or a combination of the selective serotonin reuptake inhibitors plus cognitive behavior therapy. And I think that to some extent that's a standard protocol. One of the things that's exciting at the Spectrum Neuroscience and Treatment Institute is that we can offer a more personalized treatment based on individual characteristics. That may be of great help to individuals who may not have done particularly well with the first-line standard treatments. And it sounds like there are new medication approaches that may be helpful as a augmentation strategy, that there may be a sort of a sophisticated way to use cognitive behavior therapy in conjunction with medicine treatments. There may be some new novel treatments like transcranial magnetic stimulation or even deep transcranial magnetic stimulation. That might be helpful in modifying these frontostriatal thalamic circuits that we know drive these repetitive thoughts and behaviors. What do you think about the idea of personalized treatments for OCD?
I think that especially after that the first-line treatment has been proven, you should. I mean, because we don't, we are aware that different symptomatology can correspond to different circuitry involvement and probably if even different balance between different neurotransmitters. So I mean, we now know that we can integrate in a different way all these different treatment, and I think that most of them are very safe. So there is no problem. Is not a big issue to integrate different substance, psychological intervention, or also transcranial magnetic stimulation at the same time.
Right. Well, it does sound like there are exciting developments in terms of neuroscience and our understanding of the basic circuits that really drive these obsessions and compulsions, and our understanding that a number of these different conditions really may share some common underlying features, and that you can use treatments that have different mechanisms of action and that they can have synergistic effects. What's your thought, for example, in terms of combining cognitive behavior therapy or medication or transcranial magnetic stimulation or other modalities in a personalized type of an approach?
So I think really the combination tends to work well. One of the reasons we kind of often need to target OCD in a personalized manner from so many directions is unlike some disorders, OCD rarely kind of walks alone. It's most often there's another disorder, what we call a comorbid psychiatric disorder, along with the OCD. Things like ADHD or mood disorders like depression or bipolar disorder. And so we often have to kind of personalize the treatment, not only the behavior therapy, but the medication treatment, according to what these kind of comorbid conditions that go along with the OCD are. And often that's something here at Spectrum that we really kind of focus on. Often when we have refractory patients that haven't had success, we often find it's due not just that the OCD is not being treated, but because these comorbid disorders aren't being treated, such as ADHD or bipolar disorder, often it doesn't allow for the OCD to improve. So really kind of targeting not just the OCD, but the comorbid conditions axis allows us really to personalize the treatment and get a much better response than we would otherwise.
Mm-hmm. So what do you think about the idea of these other comorbid conditions? What do you think are the toughest sort of comorbid conditions that complicate the treatment of OCD, and what are you sort of on the lookout in terms of optimizing treatment?
No, I think that is a very important point. I mean, even because it's true that probably more than 90% of OCD, at least the patient that come to seek for some treatment have some comorbidity. Probably we don't see much people without any comorbidity. But the toughest is probably the schizoobsessive form of these disorders, where that is really, there are not really guidelines. We know that we can try with some anti-obsessional agents, but we have also be aware that some of the neuroleptic can produce or precipitate obsessive-compulsive symptom in schizophrenic patients. So that requires specific mastery in organizing the treatment. The other killing doctor, comorbidity is comorbidity between bipolar disorder and obsessive-compulsive disorder. My recommendation is when you find you are sure that you find a bipolar disorder under the OCD presentation, you should care first of the bipolar disorder and then of the obsessive thought, because otherwise you cannot use on the first as a first step, anti-obsessional agents, but you have to calm down the affective instability, and then you can try with some of the anti-obsessional agents. Sometimes, if you can have a great reduction of obsessive-compulsive symptoms just producing a stabilization of the mood. So,
well, it certainly sounds that many patients with obsessive-compulsive disorder can have comorbid bipolar disorder, and it's really hard to get a handle on the obsessive-compulsive disorder until you really optimally mood stabilize first. And I guess sometimes if you can really improve the bipolar disorder, then you have an opportunity to get some improvement then in the OCD. Now, you had also mentioned two other comorbid conditions, attention deficit disorder and also tics. Want to say anything about how those comorbid conditions can influence treatment?
Sure, and it's very interesting that we bring up both ADHD and tics, because actually we often see that kind of triumvirate of three conditions. And there probably is a subtype that's probably more often in males where they have both tics, ADHD symptoms, and OCD. And for the ADHD symptoms, the standard treatments for ADHD are stimulants. And for many years, people used to think that you couldn't give stimulants to somebody with OCD, that it would make their condition worse, when the case is that does sometimes happen, but often we find that when people with ADHD symptoms comorbid to the OCD are given a stimulant, they often improve. And even some patients without ADHD, there's some evidence that low doses of drugs like amphetamine can be helpful for some people's OCD condition. With tics, often we find that these are the patients, and the standard treatment for tics is often atypical or typical antipsychotics, and these are also medications we use as augmenting medications for OCD. And people without tics with OCD often improve when we add a atypical or typical neuroleptic or antipsychotic to an SRI. And we actually find that when people have comorbid tics or certain obsessions, compulsions like symmetry, those patients even do better on antipsychotics for their OCD than regular OCD patients. And so often kind of treating these comorbid conditions, we find not only does the tics and the ADHD improve, but we get those under better control. Often we find the OCD actually gets much better as well.
Mm-hmm. Another comorbid condition that we see that really is underappreciated is the whole idea that patients with autism spectrum disorders, high-functioning autism or Asperger's in particular, can sometimes complicate obsessive-compulsive disorder. So clearly people with Asperger's or high-functioning autism can have substantial OCD symptoms as part of their underlying problem. And in fact, in many sort of specialty centers for resistant OCD around the world, many of the patients who are coming into these resistant OCD centers actually have undiagnosed Asperger's or high-functioning autism. So do you see that in Italy? What do you think about that comorbidity or co-occurrence?
Yeah, I think that if you are aware of this possibility, you will see a lot of this comorbidity in autism, either with obsessive-compulsive and with other anxiety disorders. Mm-hmm. One other condition that is usually underscores the comorbidity with substance abuse and OCD. This is another, and actually it makes sense with the new conceptualization of the OCD as a disorder that now, as you have said at the beginning of this presentation, is not just considered as an anxiety disorder, but it's considered more as a reward dysfunction disorders. So it makes sense that people with such a dysfunctional relationship with reward and gratification can find some reward instead in a substance and then get addicted.
Well, that's a very new sort of understanding, is that, you know, sometimes obsessive-compulsive disorder itself can have addictive-like features, and that sometimes you can look at addictions as being compulsive behaviors as well. Now, do you want to say something about how you might go about treating the underlying sort of brain circuitry of OCD with transcranial magnetic stimulation?
Yeah, I mean, there are several different protocols for the treatment. The one that, and there are already several studies, some positive, some not so positive, but the most interesting line since the application of low frequency of the motor supplementary area. I mean, the general model is that you have a hyperactivity in that area, and if you reduce the cortical hyperactivity in that area, you can get a better control of the obsessional thought and of the dysfunctional ego-dystonic sensation that and feeling that subject can happen. So I think that is a very promising way of treatment.
Now, do you ever use group approaches to treat obsessive-compulsive disorder?
So we do. Often group approaches are really an excellent way to kind of, you know, treat patients with OCD, often allowing them to kind of look at the symptoms of other people and how they're treated. It often helps them kind of get a better sense of how to treat their own symptoms, and the support. You know, one of the things that we should talk about is any of these disorders, including OCD, can often be very isolating, and the social isolation and really kind of some of the embarrassment people have in not being able to talk about their condition. And so being able to put people with OCD in a room with other people that suffer from a similar condition, that in of itself can be incredibly therapeutic, and really kind of help them kind of attack their symptoms.
Well, we've been hearing a lot about obsessive-compulsive disorder and related conditions. We've heard that obsessive-compulsive disorder is common, that it's a brain-based disorder, that there are exciting new developments in terms of DSM-5 and looking at a group of obsessive-compulsive spectrum disorders. I think that there's a rapid change in our understanding of the basic neuroscience, the neurotransmitter systems or receptors, brain circuitry involved, and there are a range of complementary different kinds of treatments. I think that the exciting thing really these days is that we're seeing that there's a lot of comorbidity, that different conditions can co-occur, and that a personalized approach where we really match the different treatment modalities to the specific symptom clusters and comorbid conditions of the individual is really the way to go. And the idea is that we can use different modalities to get an optimal approach in any individual. I guess having a sort of a subspecialty center with people who have training in different disciplines can be very helpful as well, because people bring different things to the table. Do you have some final comments for the audience?
I guess one of the probably most important things is that OCD can be a very treatable condition. And people getting kind of early recognition of symptoms. Often one of the main problems we have is that by the time people get to a specialty center like ours, they've had these symptoms for years and years, and as has been discussed, similar to an addiction, the more these symptoms go on, probably more these circuits kind of get hardwired. And so the quicker I think we can get people into treatment and involve not only our treatment center but the family and the community, the more likely we have a chance of getting a positive response.
Great. Do you have some final comments as well?
No, I was totally agree with what Steven said. I think the duration of a treated illness is really the most difficult barrier in order to get good enough treatment at the beginning. I think that people should not be ashamed at this point of this old thinking, and because we know what are the meaning now of this disorder, and it is a treatable condition. This is a message, I think, that is the most important part of the message.
Okay, well that's great. So it's been a great pleasure to be here with you. My name again is Dr. Eric Hollander, and I'm here with Dr. Stefano Pallanti and Dr. Steven Poskar. And this has been part of our mini lecture series at the Spectrum Neuroscience and Treatment Institute. Thanks.